You are listening to the Horse Radio Network, part of the Equine Network family.
Hello and welcome to this episode of the Disease Du Jour podcast. Today, Dr. Laura Javsicas is joining us to discuss neonatal field care. I'm your host, Carly Sisson, Digital Editor of Equimanagement. The Disease Du Jour podcast is brought to you in 2024 by Merck Animal Health. Dr. Javsicas grew up outside of Philadelphia, Pennsylvania, where she enjoyed riding hunters and jumpers. She received a bachelor's degree in biology from Cornell University, where she was co-captain of the equestrian team. Javsicas then returned to Philadelphia to attend veterinary school at the University of Pennsylvania. After receiving her VMD in 2004, she did a one-year internship at Hagyard Equine Medical Institute in Lexington, Kentucky, which furthered her interest in critical care medicine and neonatology. Javsicas then completed a 3-year residency in equine internal medicine at the University of Florida. Following her residency, she stayed on at the University of Florida as a member of the faculty. In 2009, she moved to Saratoga Springs, where she worked at an equine clinic providing in-hospital internal medicine services and general ambulatory care, until joining Rhinebeck Equine in 2013. Javsicas is board certified by the American College of Veterinary Internal Medicine and Large Animal Internal Medicine, and has special interests in neonatology, ultrasonography, cardiology, gastrointestinal diseases, and emergency critical care medicine. Thank you, Dr. Javsicas, for joining us on this episode.
Thanks so much for having me.
So, how soon should a veterinarian visit a newborn foal, assuming it was a low-risk pregnancy and the mare foaled out at home pretty normally?
I think that depends a little bit on what your intervention options would be if you did find a low IgG with that foal. And what I mean by that is that if there is colostrum available, any sort of colostrum bank, either at your practice or on farm or locally, then I really like to examine foals ideally between about 8 to 12 hours after birth, so that if I detect a low IgG, then I'm able to supplement with colostrum in the window during which they would still absorb the colostrum. If there's no colostrum available, and that's not even going to be an option, then it may be fine to wait a bit longer up to about 24 hours, but I really like to look at them before 24 hours of age at the most, assuming that foal's doing well clinically. The other thing I just wanted to mention with colostrum is that it's really handy if you or owners, if they have multiple mares foaling, have a Brix refractometer available so that they can measure the quality of the mare's colostrum, because that could be an early key that that foal is more likely to have a low IgG, failure passive transfer, if the colostrum quality is very poor. And that's a very easy test to do.
Now, besides IgG, what else would you check for during that initial visit?
So I always like to check CBC and IgG at a minimum. Some of our farms now do run an SAA as well. In our practice, IgGs and SAAs are run stall side, while the CBC we bring back and run in-house. It's certainly absolutely fine if that blood work needs to be sent out as well, the CBC specifically. But having the stall side IgG is really, really helpful, so that, again, you can intervene either by giving colostrum or plasma, depending on the case. And then in terms of what I look for with my physical exam, I think it's really, really important to always observe the foal first from the outside of the stall. You can really learn a lot about if they have normal behavior and if to detect any issues just by watching them. So if that foal is up, you want to make sure that they are interested in nursing, have an awareness of their surroundings, interacting appropriately with the mare, moving freely around the stall without a very high respiratory rate, no signs of abdominal distension, anything like that. And so after that observation from outside the stall, I always do a complete physical exam, including looking at mucous membranes. I like to look at the tongue. Some sick, compromised foals can develop a fungal infection, typically candida, on the surface of the tongue. I do palpate the palate carefully. Most cleft palates occur in the soft palate, and you're not able to feel them. But with the rare occasion that there is a palpable cleft palate, you certainly would not want to miss that on your physical exam. And then I always look at the sclera of the eyes carefully for any signs of hemorrhage, which can happen with trauma during birth. and look in the ears for petechia. That's a good place to see petechia if it is there, which can be associated with sepsis. I palpate the ribs very carefully. I like to do that by running my hand down both sides of the chest at the same time to feel for any asymmetries. And I just find it easiest to palpate any clicking ribs or any calluses when I'm feeling both sides simultaneously with the full standing. I pay close attention to the umbilicus, make sure that there's no large hernias, that it's not torn too close to the body wall or bleeding excessively or any abnormalities there. And then I always palpate all joints very carefully. I really like to watch the foal ambulate, assuming they are up and ambulating. And I look at the coronary bands as well. Septic foals can develop erythema, redness around the coronary bands. And then body temperature, it can be high or low if there's a problem going on. So it is always important to get a temperature as well. So that's my basic full physical exam. If possible, if the foal is down and sleeping, I do encourage them to get up so that I can watch them nurse and get a chance to watch them move around the stall as well. And it sounds like a lot, but all of that can be done quite efficiently, especially once you have your system down for doing that physical exam.
Yeah, it sounds like a great checklist. Do you have any specific milestones that you want to see newborn foals hit by certain time intervals?
Yeah, definitely. I mean, there's the well-known 1, 2, 3, meaning 1 hour to standing, 2 hours to nursing, 3 hours to passing meconium. There can be some variation in that, but I think it is a good rule of thumb and certainly a good thing for owners to be aware of and to make sure that the owners are paying attention to and ideally are writing down somewhere. It's always nice. Our well-managed farms always have a nice record of when the foal was born, when they've met all those milestones. And it's really nice to be able to refer back to that when I'm examining the foal for the first time. And then some other things immediately after birth for the person who is attending the delivery would be that foal should develop a suckle reflex very early on, anywhere from about 5 to 20 minutes. They should have a strong suckle, and then they should already be able to sit sternal by about 10 minutes. And another thing that was one of these things that's really nice to observe from outside the stall and also to ask the owners about is how much the foal is nursing. So both in terms of frequency and how long each nursing episode is, meaning if the foal is standing at the udder for 5 minutes solid at a time and nursing, sometimes they just won't leave the mare alone. That usually is an indication that mare is not producing enough milk for the foal. Whereas certainly decreased nursing activity is a big red flag for a number of reasons. So a normal foal should nurse a minimum of 1 time per hour. Most completely healthy foals nurse twice an hour. So it's a good thing. You may not be able to see that during your exam, but hopefully that is something that the owner has been paying attention to.
Now, are there any other red flags that you would look for that might indicate that something's wrong with the foal, either very subtle signs or more glaring signs?
Sure, yeah. So I think in addition to any break from those milestones that we reviewed, for me, the biggest one is always decreased nursing activity. And that is a very non-specific sign, but is a huge concern because foals can become dehydrated and hypoglycemic fairly quickly. And so my top differentials for that would typically be septicemia, neonatal maladjustment, and I would also wonder if they're developing diarrhea or any form of enterocolitis. In addition, certainly acting interested in nursing, but seeking the udder, nursing on incorrect objects, stifles, etc., is certainly a big concern. And then one thing that I often will see in that initial observation from outside the stall is an increased respiratory rate. So if that foal is either laying down or standing and really huffing and puffing, or if that foal is standing and not wanting to lie down, or the owner has not seen them lay down at all, I always want to make sure I check those ribs extra carefully because I do see that a lot with fractured ribs. They are painful, they don't want to lay down, and breathing, particularly if they are laying down, they tend to have quite an increased respiratory rate. So those are good things to look for. Certainly on that physical exam, if I notice any icterus within the mucous membranes, I would be worried about neonatal azoerythrolysis. However, it's important to know that depending on the age of that foal, they may have NI and may not have icterus yet. So if it's in the very early stages and their bilirubin levels have not increased to the point where their mucous membranes are actually icteric, you may just see a quiet foal that's not nursing and is often a little bit tachycardic and tachypnic. So because of the anemia, then their heart has to work extra hard. So those are some subtle things that would make me more suspicious of an eye. Another, other common things we'll see would be straining to either urinate or defecate. And I find that that's something that confuses owners. They don't always know. They know the foal is straining, but they may not know what they're straining to do. So it's a place where technology can be our friend, because if I'm not there physically examining the foal, having someone send me a video or at least a picture of exactly what that foal is doing can be very helpful. So if they're straining to urinate, certainly I always worry about a ruptured bladder, particularly if it is a colt. And if they're straining to defecate, then I worry about meconium impactions, which are the most common cause of colic in that 24-hour period, first 24 hours of life. It's important to ask if the foal has passed meconium. However, they certainly can have an impaction that is significant enough to cause clinical signs, even if they did pass some amount of normal meconium. And then one more thing I would mention is that we see quite commonly is flexural deformity, so either severely contracted tendons or severe laxity. And my big question there is it affecting the foal's ability to nurse as frequently as they need to, because they, again, of course, can become quite dehydrated if they're not nursing with normal frequency. So that may be something that needs attention.
Today's Disease Du Jour podcast is brought to you by Prestige Vaccines from Merck Animal Health. Raise your standard in equine vaccines with Prestige. From a worldwide leader in vaccine manufacturing and innovation, the Prestige line has an enduring reputation of performance. Known for their safety and efficacy, only Prestige vaccines are backed by the Merck Animal Health Respiratory Biosurveillance Program, which helps practitioners create new standards of care and improved infectious respiratory disease management. Learn more at merckanimalhealthusa.com. What are some risk factors that might predispose a foal to potential problems, such as high-risk pregnancy or environmental concerns, and how can you prepare to address these issues?
There's so many. There's a long list, but any kind of maternal illness, so severe colic, particularly if the mare has required colic surgery during gestation, history of placentitis, if that mare bagged up early, had any abnormal discharge, things like that, dripping milk, whether because of placentitis or for other reasons, certainly are red flags. Twin pregnancies, if it was reduced, or even if it was reduced naturally, and the remaining fetus can be at increased risk. Prolonged gestation, we do see some issues with those foals being dismature when they're born, depending on the mare. And some mares always carry a long time and have completely normal foals, but having that history can be helpful. And then one thing we see quite a bit too is mares that are in chronic pain during gestation for any reason. Most often, I would say we see it with laminitis, but it can just be severe arthritis as well. And as they get heavier, they get more uncomfortable. In terms of preparing to address those issues, it can be challenging. I think just making sure that people are prepared to monitor that foal very closely and make sure that all those milestones are being met. Alternatively, depending on the severity of those issues, it may be appropriate to have that mare full out at a veterinary facility. We full out a number of high-risk mares here every year, and we're always happy when there are not complications, but more often than not, either the mare or the foal does end up needing some kind of intervention, and it's great when there are veterinarians close by to attend to those quickly. I think one thing that we do more and more is having an ultrasound done when the mare is closer to term, a transabdominal ultrasound to assess that fetus, a transrectal as well to look at the placenta. But we commonly, when we have high-risk mares here, we commonly ultrasound them and can determine which way the foal is facing, which may help us have a higher degree of suspicion that there will be maybe a dystocia. She may require help. And then it's always an important consideration to have a conversation with the parties involved to determine if that mare does have a C-section option prior to it becoming an emergent situation so that we can move as quickly as possible if needed to get that foal out. But it's really, there's so many different issues. I think having somebody knowledgeable in ultrasounding the pregnant mare in the third trimester can be very helpful in a number of cases.
So we spoke a lot about common problems with newborn foals, but are there any problems that might arise slightly later when the foal is like a couple weeks old?
I would say the most common things we see at a few weeks old would be diarrhea and also respiratory disease, primarily R. E. coli, rhodococcus pneumonia. So again, what I see most often with the foals that are developing diarrhea, obviously the owners may notice the diarrhea, but just decreased activity, decreased nursing, and those foals can become dehydrated extremely quickly and also can develop very severe electrolyte abnormalities that can be quite challenging to treat at times. I always caution people to be careful that the foal is not drinking a tremendous amount of water from the mare's plain water from the mare's water bucket, because they can dilute their sodium out very quickly if they do have diarrhea and are losing electrolytes that way. So that's something to be on the lookout for. And then certainly there are other causes of colic later at the few weeks to month old time frame, because they can develop small intestinal volvulus, the root of the mesentery we see pretty commonly in that age group as a cause of more severe colic, and that they can do quite well with rapid surgical intervention, but it does need to be diagnosed and addressed quite quickly before that intestine becomes too compromised. In terms of rhodococcus, it's really highly dependent on the type of situation you're in, meaning is an endemic disease on that farm. In our area, we do see a lot of endemic rhodococcus, and using hyperimmune rhodococcus plasma is quite commonplace. We are now tending to use a larger volume of plasma, 2 liters per foal is what we recommend. However, that is, of course, quite expensive, and so not everyone will go for that. And so I try to talk through the cost-benefit analysis on a farm and individual foal basis to determine if that's something we want to do. I think that monitoring foals at that age is really key. And when I say monitoring, really just physical observation, visual exam, and taking their temperature at least once a day, if not twice. If it is done once a day, I prefer that it is done later in the day, because they tend to have fevers later in the day. I will say that the biothermal microchips have become very popular on our local breeding farms, and they are really great because they allow the farm personnel to get temperatures on the foals very easily without a lot of extra hands. And that's a great monitoring device. So depending on the farm and what disease we're worried about, we may institute things like ultrasonographic screening for rhodococcus, but we need to be very careful with that so that we don't end up overtreating foals that are actually subclinical for the disease and may resolve anyway, because we're starting to see a lot of antibiotic resistance with rhodococcus. So that's sort of a whole other talk in and of itself. But just to say, I think that the visual exam and temping of the foals frequently is really important. And then the other thing I would mention in that age group is just that as they start to get turned out more, they are rambunctious youngsters, and certainly we see quite a few injuries. We can also see septic joints in that usually few-week-old foals that may have had sepsis or may have had an umbilical infection earlier in life that seeded a joint. So any lame foal should certainly be examined promptly and appropriate diagnostics done.
How would you determine what conditions you would feel comfortable treating in the field versus conditions that would require referral to a hospital?
Yeah, it's so hard to generalize about that, because I think it is so dependent on the available farm staff and their capabilities. I've worked at farms that have licensed vet techs and isolation facilities and fluid pumps, and I've worked at places where they don't want to even attempt to handle any remotely sick foal and everything in between. So it's certainly hard to generalize, but I never think it is wrong to refer a foal that you have health concerns about, especially if you don't have very capable staff on farm, and depending also on how frequently that foal is going to be observed. If it's the only foal on the farm and the people want to go to sleep at 9 and see the foal again at 8 a.m., if there's anything wrong, that foal should be referred. Whereas, a commercial breeding farm that has staff there all night because mares are foaling, that may be a different situation. So it is highly dependent on the exact situation. But I think I always prefer to see foals much earlier on when there are concerns than when people wait too long. The prognosis is always better if we see them earlier. That being said, I think if we go back to sort of some of the conditions that I mentioned earlier on, there are a number of things that can start to be addressed on farm. Meconium impactions, my rule of thumb is that they can have soapy water enemas on farm, and then if it's not improving, they're getting distended, they have any gastric reflux, then I prefer that they be referred. In some cases, we will perform acetylcysteine enemas on farm, but that's not something that everyone is comfortable doing, and it also takes time. So if you're not able to sit there with the foal to do that, then it's best to refer it. And those cases also sometimes benefit from restricting nursing activity for a period of time until things are moving through. Foals with diarrhea that aren't nursing well, I think definitely should be referred because of the electrolyte abnormalities that I mentioned earlier. Those require close monitoring and tweaking of fluids. And so those foals typically are best managed in a clinic. Things like failure of passive transfer, we most often are addressing just on farm. Contracted tendons can go either way. If it's so severe that the foal is not able to stand a nurse, then often that is something that would be best managed in a hospital so that we can address the contracted tendons, but also so that we can ensure that the foal remains hydrated. One thing I see a lot in those foals is that we may be giving them oxytetracycline to try to relax the tendons, and that can cause secondary renal damage, which is more common when the foal is dehydrated. So in severely contracted tendons, if it's inhibiting their ability to nurse, I would recommend referral. But again, there are plenty of mild contractures with only one leg involved that can certainly be addressed on farm as long as you're comfortable placing a splint or using something like a red boot to try to address that contracture. Rib fractures, it really depends on how many ribs are fractured and where they are. So anything over the heart definitely is of higher concern. And I should say at how displaced those fractures are. Ultrasound is really, really handy to assess rib fractures. You can easily tell how displaced they are and often can find fractures that you may not have been able to palpate. So those, depending on the location, certainly may require referral and sometimes surgical intervention if they are at high risk of creating an issue, i.e. either close to the heart. Neonatal maladjustment, dummy foals, there's such a wide range. The foals that are recumbent, unable to stand, typically I would almost always recommend referral in those cases, whereas if they're ambulatory, just searching for the udder, then they may be able to be treated on farm if you're comfortable placing a feeding tube so that they can receive supplemental nutrition that way. I vastly prefer the small diameter feeding tubes that they're able to have in place while they nurse as well, because that way you can supplement them and ensure they get the needed hydration and calories while they're still able to figure out nursing with the tube in place.
Great. Well, I think this has been a really helpful overview. I know this is a really broad subject, but I think this has been a good refresher for veterinarians heading into the heat of breeding season. Do you have anything else you want to add before we wrap up?
I'm sure I've forgotten a lot of things, but not that I can think of at the moment. I'll remember as soon as I'm done.
Thank you so much, Dr. Javsicas, for joining us on this episode, and thank you so much to our audience for listening, and a very special thank you to our 2024 sponsor, Merck Animal Health, for allowing us to have these conversations. If you're enjoying the Disease Du Jour podcast, we would really appreciate if you would rate and review us wherever you're listening, and if you have any questions or suggestions for the podcast, please send me an email at csisson@equinenetwork.com. That's CSISSON@equinenetwork.com.